Well, I see it's 12 o'clock, and to respect those that have come for the presentation on time, I think we will start. Um, I'd like to acknowledge that we're gathered on the traditional and ancestral unceded territory of the Coast Salish peoples. Today's presentation is pulmonary artery pressure monitoring and heart failure. Dr. Brian Clark. And Dr. Clark and I were just talking, since he and I haven't met. He's a recruit to cardiology via medical school and training in Dalhousie in California, with a staff position in Dalhousie, then University of Calgary, and now for the last year and a half here. So he brings a lot of knowledge and expertise to this area. So without further introduction, pulmonary artery pressure monitoring and heart failure, Dr. Clark.
Thanks so much, Barry. It's a pleasure to be here today. So as Barry said, I've kind of slowly made my way west. I guess I'm a mid-career recruit, is what I would be technically called, working in Halifax for a few years as a heart failure cardiologist, and to Calgary for 6 or 7 years, and then since the fall of 2021 here in Vancouver. So my primary area of practice, both clinically but also research and administratively, is in heart failure cardiomyopathy, and of course that would include advanced heart failure as well in the mechanical support and transplant world. But today I'm going to be talking to you about a topic that is significantly of interest of mine, an area of research and clinical innovation, and some work that I'm doing here in BC as well. So of course, my disclosures are relevant to this talk. Abbott Laboratories is the producer of the CardioMEMS technology, of which I will be talking a lot about today. So my objectives this afternoon are to provide an overview of heart failure clinical trial outcomes with remote monitoring strategies, to review the pivotal CHAMPION clinical trial and real-world evidence with the use of pulmonary artery pressure monitoring, to highlight the challenges with the existing remote monitoring data we have for heart failure, and to identify the opportunities for a renewed and refined investigation on the utility of remote monitoring strategies and how best to integrate them into models of care. So the background, as we all should be well aware of, is the burden of heart failure is extremely significant, as is the cost. And really, despite device and medical improvements over the last decade, there has been modest prognostic improvement along with that. In Canada, we spend over $2.8 billion per year on direct heart failure costs. That does not count for indirect costs related to this condition. And the cost, morbidity, and mortality of heart failure are intimately linked to hospitalizations. Rehospitalization rates remain extremely high. So all-cause rehospitalization at 30 days, about 25%, 50% at 6 months. And these statistics hold true now compared to where they were 10 years ago. For heart failure specific rehospitalizations, a little bit less, but still significant. So about 15% rehospitalization rate within the first 30 days of a heart failure hospitalization. And we know that more than 90% of these heart failure hospitalizations are because of persistent and recurrent congestion. So fortunately, improvement in our coronary outcomes over the past decade have resulted in significant reductions in coronary deaths over the years. But this means better survival in coronary artery disease, which is a good thing. But we do see increases in heart failure and heart failure-related morbidity as a consequence. We are reminded of the prognostic importance of heart failure decompensations by this contemporary analysis of the Paradigm HF trial. And recall, the Paradigm HF trial was the pivotal trial that demonstrated the superiority of our ARNIs in heart failure with reduced ejection fraction. Looking at data from this study, all decompensation events, so whether it be outpatient intensification of therapy, ER visits, or hospitalizations for worsening heart failure, they all had similar association with increased all-cause death and cardiovascular mortality. Now, intensification was defined as an increase in sustained diuretic use and administration of IV diuretics, or the addition of a new drug for the treatment of worsening heart failure. And this figure reports the mortality in percentage after the first event or in a person with no event. You can see that it's still fairly significant. We also know, and this is data from BC actually, a bit old data now, but it is BC data, that heart failure hospitalizations have an additive effect on overall mortality, with higher mortality and less median survival with each subsequent hospitalization. And in this study of over 14,000 heart failure patients admitted in BC between 2000 and 2004, you can see that mortality increased with less median survival post-discharge with each subsequent heart failure hospitalization. We also know that clinical examination, although still extremely useful and critical in evaluating monitoring heart failure patients, they're not highly predictive in assessing worsening heart failure. And this table really shows the performance characteristics of clinical examination. So sensitivity, specificity, and positive predictive value, negative predictive values in our usual measures that we do in clinic all the time in determining a heart failure patient's hemodynamic profile or status. So right atrial pressure measured by raised JVP and edema. Cardiac index is measured by proportional pulse pressure. Wedge pressure or indirect assessments of LV filling measured by third heart sounds, dyspnea, rails. And clinically, we try to estimate filling pressures through examination and patient symptoms. However, as you can see here, these indirect measures have poor sensitivity and predictive value. Pharmacotherapy in heart failure with reduced ejection fraction is improving, but outcomes or improving their outcomes, but care gaps still do exist. So when we look at rehospitalization rates in our contemporary data, so despite all of our great advances in medical therapy, we have heart failure hospitalization rates in excess of 10%. And these would be most of our contemporary clinical trials with now our modern medical therapy. And we still have no robust evidence-based interventions to improve outcomes in heart failure with preserved ejection fraction. So can how we deliver care to patients with heart failure affect their outcome? And well, we know the answer to this is yes, and we have data supporting the establishment of heart function clinics with demonstrable improvements and outcomes in heart failure patients. But in Canada, as is elsewhere, there's substantial regional variation in access to services involved, location, staffing, and capacity. And this is also coupled with the fact that the majority of heart failure patients, and by far the vast majority of heart failure patients in Canada, are managed by primary care and internal medicine specialists. So the minority are actually enrolled in heart function clinics. So can remote monitoring, can this help? So what do we mean when we say remote monitoring? And remote monitoring has many related definitions. And Canadian Health InfoWay has defined remote monitoring as the delivery of healthcare to patients outside of conventional settings enabled by a technologic application or device. So we have remote monitoring for heart failure patients available in several forms. So we have structured telephone support services with frequent review of heart failure symptoms, weight, medication compliance, and a medication plan adjusted based on the patient's report. We have invasive devices implanted solely to monitor surrogates of left ventricular filling pressures. And we can also monitor parameters via conventional implantable electronic devices, such as ICDs, CRTs. We have a lot of emerging technology, such as patient wearables and adaptive app-based designs that are also being evaluated for heart failure monitoring. So our goals of remote monitoring in heart failure for the reduced EF patient is aggressive titration of their guideline-directed medical therapy based on symptoms, blood pressure, heart rate, labs, and physiologic variables to achieve our maximum tolerated dosages, to improve symptoms, reduce hospitalizations, and increase survival. And ultimately what we want to do is not only improve their symptoms, but improve patient-related metrics, quality of life, hospitalizations, and of course, survival. So until recently, really, clinical trials of remote monitoring strategies have failed to demonstrate benefit in improving heart failure outcomes. This is a pretty busy slide that I have up there, but basically the gist of this is prior attempts in remote monitoring have yielded neutral results. So there hasn't been any randomized trial, except for some that I'll mention, that really told us that remote monitoring in whatever fashion is beneficial to heart failure patients. So,
sorry, can I interrupt just for a second, Brian? For those of you that aren't muted,
sure, yeah, I am getting a bit of feedback, so if everyone could mute themselves, that would be great. So prior attempts of telemonitoring in heart failure with the goal of reducing heart failure, identifying it earlier and preventing hospitalizations and thereby improving overall outcomes has been quite disappointing. I've already showed you that our markers of physical examination have pretty low sensitivity, but also they're pretty late signs of decompensation. And this table that I show you outlines the studies of remote monitoring strategies, none of which have, as I mentioned, demonstrated to be beneficial. But for what it's worth, and I'll get into this a little bit later, these studies all have had issues. Adherence was poor, and it was a theme in most of them. Tele-HF was a telephone-based response system. The TIM-HF trial was a low-risk heart failure population. In the DOT-HF trial, these patients were managed with a fluid sensor in their device. And these patients actually had increased heart failure hospitalizations when they were managed by these alerts. So the gist is these studies were not very supportive of other ways of remote monitoring heart failure status. Now, an important point is what I alluded to just recently. So when we look at the time course of heart failure decompensation, physiologic markers that we currently use in monitoring, which are weight and symptoms, are very late in the time course of decompensation and provide clinicians very little time to act or react before a hospitalization. And so since we know that increase in filling pressures precede the clinical decompensation, here lies in the hypothesis that if we were able to monitor these pressure changes, can we identify pre-symptomatic congestion in order to allow time to react and alter the course of decompensation? So this forms the basis of the CardioMEMS technology. CardioMEMS is a wireless pulmonary artery pressure monitor that assesses pulmonary artery pressure, and hence it really gives an indirect assessment of the LV filling pressures. And the premise is that at a right heart cath implant, the diastolic PA pressure approximates the wedge pressure. And we all know that the wedge pressure is an indirect assessment of LV filling. So the system comprises a sensor that you can see in the photo. It's a very small sensor, and this is implanted into a posterolateral branch of the pulmonary artery through a standard right heart catheterization. The patient takes home a patient electronic system that they interrogate this device. And what this device does once it's activated is it takes a snapshot of the pulmonary artery pressure, systolic, diastolic, and mean, and transmits it to a web-based server that a clinician can access. The implant is a standard right heart cath procedure, fairly easy to do. And the implant procedure takes about 30 to 40 minutes, and the patients go home the same day. So this is what a typical homepage of a patient implanted with a CardioMEMS device looks like when you log in. Patients are educated and instructed to interrogate their device, on a daily basis, and the PA pressure is transmitted to a website for viewing. And this is what a patient's home screen looks like. So we have pressures on the Y-axis, and we have dates on the X-axis. The red line is the systolic PA pressure, the green line is the diastolic PA pressure, and the blue line is the mean pulmonary pressure. We can also see daily readings, which is the screen on the right, where we can get actually view the waveforms, and we can get heart rate information as well. We can actually open up the waveforms to get an assessment of rhythm as well. So if someone develops atrial fibrillation, we need a way to identify that as well. Patients can be entirely managed remotely with knowledge of blood pressure, renal function, electrolytes, and knowledge of LV filling pressures. Once the device is implanted, pressures are checked twice per week during an optimization phase, and then once patients are optimized, we can send an email alert and define our pressure. We can all mute ourselves as well. So we can actually set up on the system once the patient's been optimized to our liking to send an email alert once our predefined pressure thresholds are exceeded. So our targets, which I'll get into a bit later, become hemodynamic based on symptoms as well. So as I mentioned, we have an optimization phase, which is the early post-implant period where we really are doing optimal PA pressures. We do have standardized targets. Everyone can mute themselves. Are we able to mute everybody?
Sorry, Brian. Could people please mute themselves? Thank you.
Thanks. Sorry. So we do have standard hemodynamic targets, and we try to get PA pressures as normal as possible. So normal, I have listed there. Once we optimize patients, you can see that in the maintenance phase, our optimization phase is linked to interventions that include afterload reduction, vasodilators, heart rate lowering, and diuretics. And as we all know, we do beta blocker up titration once people are at a more euvolemic state. So the optimization, diuretic adjustment, and vasodilators. What's the evidence with this technology? So the Champion clinical trial is the pivotal trial that demonstrated efficacy of this monitoring strategy in improving heart failure outcomes. Interestingly, this is now over a decade old. So this is a trial that was published in 2011, and it enrolled 500 patients, all who received cardiometric heart failure system. Were randomized to treatment with knowledge of PA pressures versus without knowledge of PA pressures. So important, every patient had the device implanted. They were randomized to have knowledge of PA, the patients were randomized for their care providers to have knowledge of their PA pressures versus not have knowledge of their PA pressures. And then they were followed with time. So this figure outlines the primary endpoint with cumulative heart failure hospitalizations on the y-axis, time on the x. And compared to the control group, patients managed with knowledge of PA pressure information versus usual heart failure care had significantly less heart failure-related hospitalizations and a 28% reduction 6 months and a 37% reduction at 15 months. So this slide gives you an idea of what happens when people who were in the control group, so who were managed in the usual fashion, had when their care providers had access to their PA pressure knowledge. So in this mandated extension period, new physician access to PA pressure in the control group resulted in a 48% reduction in heart failure hospitalization rates in that patient cohort. So the figure on the left shows the hazard rates of heart failure hospitalizations in the control group and the significant reduction in the heart failure hospitalization hazard rates when patients were unblinded and physicians could use knowledge of PA pressures. On the right, the low heart failure hospitalization rate in the treatment group during the study period was maintained during the open access period. And so all taken together, these data confirm the effectiveness from findings from the randomized trial period. So several important sub-studies are important and noteworthy. So in a retrospective analysis of 337 HFrEF patients, only patients on guideline-directed medical therapy managed with PA pressure knowledge in the treatment group showed a 43% reduction in heart failure hospitalization and a 7% reduction in mortality over the 17-month follow-up. So when we looked at patients on guideline-directed medical therapy, there was a signal of substantive additional over and above guideline-directed medical therapy. Also, the effect of PA pressure monitoring in patients with preserved EF was evaluated. As an important part of this trial is patients did not need to have a pre-specified LVEF, and heart failure with preserved ejection fraction were included in this study. And we know in the real world, HFpEF accounts for 50% plus of our heart failure patients. And so this was a particularly interesting observation. So in the HFpEF group, when we looked at them in separation from the HFrEF group, PA pressure guided therapy in these patients reduced hospitalizations by 46% at 6 months and 50% at 18 months. And the effect in HFpEF was more dramatic than that in the HFrEF group, with a number needed to treat of 2. So based on this data, patients with HFpEF would need to receive the device to prevent 1 heart failure hospitalization. So when we take that into consideration of what this looks like in comparison to our other treatments for heart failure, based on the CHAMPION data, the number of heart failure patients needed to treat with PA pressures to prevent 1 hospitalization for all comers is 4. And that's really better than any device or medical therapy thus far. So what does the real world evidence show us? Because we all know that randomized clinical trials are great, but what does the real world tell us? Can we apply this to general patients? So this is a US post-approval single-arm prospective real-world study of 1,200 patients. It was published 2 years ago and reported on the outcomes of these patients followed in the real world. So in this cohort at 1 year, there was a 57% reduction in heart failure hospitalizations, and that's in figure A. So demonstrating at 1 year, 57% reduction in heart failure hospitalizations. In figure B, there was a 27% reduction in all-cause hospitalizations. And in figure C, there was reductions in hospitalizations across the spans of EF. So EF less than 40 reductions in hospitalizations, EF between 40 and 50. So it didn't matter what your EF was. All these patients did derive benefit with reductions and significant reductions in heart failure hospitalizations, and quite dramatic reductions as well. So a European evaluation of pulmonary artery pressure monitoring is presented here, and this was in over 300 patients. And the main take home from their prospective study was they demonstrated a 62% reduction in heart failure hospitalizations over 12 months. And this was consistent across subgroups, including sex, age, etiology, EF, and other factors. So fairly reproducible, and if not better, reductions in heart failure hospitalizations that we're seeing in the clinical trials. So in the European experience, they also reported on patient-reported outcomes. And a very interesting observation, which makes clinical sense, is that patients with higher baseline PA pressures derived the most benefit. So it makes sense that patients whose filling pressures are extremely high developed the most symptomatic improvement and better quality of life improvement with this device. This is another real world study now in the UK, so in the NHS system. And they have reported the highest heart failure hospitalization rate reduction to date. So this was published just last year. And at 1 year of their cohort, there was an 82% heart failure hospitalization rate reduction. So do we have any Canadian experience? And it is quite limited, primarily due to cost implications of the device and concerns of health human resource. Obviously, well, not obviously, but obviously it's been more widely adopted in the US, and few programs in Canada actually have clinical programs. So this was a program that we started at the Libin Cardiovascular Institute in Calgary when I was in Calgary, and we devised a clinical program with a research component to evaluate our outcomes, but also our economic outcomes as well. We started this in 2017, and we just published our 1 year follow-up data of 20 patients that had completed follow-up. So procedurally, we had 0% complications, and this was and has been consistent with clinical trial data and other real-world data as well, that procedurally, through a right heart cath, procedural complications are extremely rare. Device malfunctions, also extremely rare. In our cohort, we had one death. That was not due to a cardiovascular complication. But what you can see, which is very similar to the UK experience, is we had significant reductions in heart failure healthcare resource utilization. We phrased it. So we saw significant reductions in ER visits. We saw significant reductions in heart failure hospitalizations. We saw significant reductions in all-cause hospitalizations and reductions in clinic visits as well. But very interestingly, and not surprisingly, is the significant increase in telehealth that occurs in this population. With monitoring, phoning patients and remote care obviously increases the contact that we have with them. So significant reductions in healthcare utilization in these patients. And we did a crude economic analysis, certainly nothing substantive because it was only 20 patients. And this was an estimate of direct healthcare costs and healthcare utilization costs. So ER visits, clinic visits, and hospitalizations. And we saw significant reductions in hospitalization costs, significant reductions. And when we factor in the cost of the device, we actually get cost neutrality. So the total cost of taking care of these patients in this cohort prior to their device was about $30,000. And the total care to care for these patients after implantation of their device, which includes the cost of the device, was $26,000. So not really any cost savings, but definitely cost neutrality and if not cost recovery, with the main importance being significant reductions in heart failure decompensations. We also demonstrated that 85% of our patients had improvements in NYHA class, which is a significant. And again, here a different pictorial representation, significant reductions in total heart failure hospitalizations. And this graph gives heart failure hospitalizations per patient. So pre-MEMS 1.15 to post-MEMS 0.15. So an 87% reduction in absolute hospitalizations and an 86% reduction in days in hospital in that first year. This graph is really showing the medications and the interventions that are linked to these reductions and improvements in outcomes. So it's not the fact that the patients had the device that they did better, it's because the device was linked to an intervention. So we have medication changes on the y-axis and we have time on the x-axis. And remember, you know, the whole premise with CardioMEMS monitoring and PA pressure monitoring is an early optimization phase and then a later maintenance phase. So not surprisingly, there were a significant number of medication changes occurred within the first 3 to 6 months with a tailoring off of medication changes once we were able to stabilize patients. By far, the most common medication change was an increase in changes in diuretics, which is the purple line. The second most common change in medications were your vasodilators or afterload reducers, so ACE, ARBs, and ARNIs. The third most common change medications were rate control, so ivabradine and beta blockers, followed by additional vasodilators like nitrates, hydralazine, followed by MRAs, and then followed by SGLT2 inhibitors. So we know from clinical trial and real world data that remote monitoring with PA pressure monitoring really has been the only monitoring strategy with actual clinical trial evidence supporting its impact on heart failure outcomes. Very important, as I mentioned, that knowledge of this data is linked to an intervention. So it's not the fact that these patients have the device, it's the intervention that's linked to the knowledge. It's this intervention that's responsible for improved outcomes in heart failure with this technology. And it's this intervention that's linked to active monitoring and action. Extremely important with the intervention linking is compliance. So both sides compliant. So the information is only as useful as we get it. So patients have to be compliant in sending us their information and trusting that the medication changes that we make, they're actually doing. But clinician compliance is also extremely important. So we need to be actively monitoring these patients and staying on top of them. More recently, there was a published trial which has cast a bit of doubt on the effectiveness of implantable pulmonary artery pressure monitoring. And many of you may have heard of the GUIDE-HF randomized clinical trial, which was published in the Lancet just last year. Now, GUIDE-HF is important for two main reasons. So the first is that it was looking for an expanded indication. So CHAMPION enrolled patients who were sick. So it was an NYHA class 3 patient population who had a heart failure hospitalization in the last 12 months. GUIDE-HF tried to expand that. So they included NYHA class 2 patients, but also they did not require them to be hospitalized. They were also looking for a mortality benefit, not only looking at a primary endpoint of heart failure hospitalizations. So GUIDE-HF took 1,000 patients, class 2 to 4, either with a heart failure hospitalization or elevated NT-pro or BNP, so elevated natriuretic peptides, and randomized them to management with knowledge of PA pressures versus management in the usual fashion without PA pressures. However, this trial was impacted by COVID, as were so many research studies during the pandemic. And a lot of enrollment occurred during the COVID pandemic, and several interesting things happened that the investigators of this study felt required attention. So the first thing is that the heart failure hospitalization rate dropped significantly, and we observed this clinically. So patients were not coming to hospital anymore with heart failure decompensations. The event rate dropped. And of course, when we're looking for effective intervention, if the event rate drops, any potential benefit of an intervention is harder to demonstrate. And patients who actually had their PA pressure monitors had way more stable PA pressures. So there was some behavioral change that the investigators hypothesized that being restricted at home played in their overall management and status of their heart failure. So the overall trial was a neutral trial. And so these are Kaplan-Meier curves that I'm showing on the right. So in the top left panel is the overall Kaplan-Meier curve of the primary endpoint, which was all-cause mortality, heart failure hospitalization, and urgent heart failure visits. So there was no significant difference. There was also no significant difference in heart failure hospitalizations as a secondary endpoint. But midway through COVID, the investigators designed and developed an protocol amendment to do a pre-specified subsensitivity analysis for the effect of COVID. And very interestingly, when they looked at patients who were enrolled in the study pre-COVID, there was a suggestion that this technology offered benefit, that during COVID, that experience nullified the benefit. So in patients who were enrolled and managed and had follow-up data pre-COVID, there was a suggestion that there was a reduction in mortality and a reduction in heart failure hospitalizations. But overall, this trial was reported as a neutral trial. In addition to the trial and real-world data that we have that tells us that it potentially has benefit in a subset of heart failure patients, we also need to recognize that it really truly is an opportunity for personalized medicine. And personalized medicine is becoming very topical and important of late. And really, this technology provides us a great example of this. And I'm going to take you through a couple of examples, real patient examples, to show you what I mean by this. So this is a patient, actually our very first patient in Calgary that we implanted with the device. So a congenital heart disease patient, a young woman with Shown syndrome, so left-sided lesions, coarctation, bicuspid valve. She underwent a mechanical mitral valve replacement in 2015 for mitral stenosis, and she developed heart failure post-surgery. And this was due to a comprised circumflex occlusion during her mitral valve regurgitation. She also had paroxysmal atrial fibrillation, and she was obese. And she was really struggling with heart failure post-surgery. An unfortunate complication of her surgery that she developed LV dysfunction with corrective mitral valve intervention. And so she met clinical indication. She was NYHA class 3. She had a heart failure hospitalization in the previous 12 months. And so we implanted her with a CardioMEMS device. And you can see that this gives you the trend of your PA pressures over time. All those yellow lines are medication interventions. And you can see generally and gradually we got improvements in her PA pressures, but with a lot of effort. So initially, on the far left of the screen, you can see a lot of improvement and change. But unfortunately, we pushed her into renal failure and had to stop all of her medications. And then she very quickly spiked again. We saw some diuretic resistance. And so the second arrow, when we switched her diuretic to a different formulation, she responded better to that diuretic. She responded better to being off ACE, ARBs, and ARNIs and on more hydralazine nitrates. And then over the next couple of weeks to months, you can see a very nice decline in her PA pressures on differential medical therapy. The third arrow, very interestingly enough, was she wanted to lose weight. So she was started on Saxenda for weight loss. And you can see a dramatic decline in her PA pressures with Saxenda. So you say, is there something going on here with Saxenda? Well, no. She was so nauseated from this medication that she really stopped eating and drinking. So really giving you the visual concept that there is definitely a subset of heart failure patients who are extremely sensitive to fluid and diet. When she stopped her Saxenda and started back to kind of normal appetite, you can see a rise in her PA pressures. You can also see in the last arrow the effect of adding SGLT2 in her a bit early for its indication and coverage. But because of the diuretic effect, we started her on this and she did respond favorably to it. So in this patient, you can see, right, a great example that we're able to make frequent medication changes. We're able to individualize immediately. So we can make a change, assess its response, make another change, assess its response. And we know that everyone's a bit different. What someone responds to, another person may not respond to. We managed this young woman almost entirely virtually. So email with knowledge of blood pressure. We improved her symptomatically to class 1 to 2. We improved her objectively with a cardiopulmonary exercise test with significant improvements objectively in her exercise tolerance and quite dramatic reductions in her PA pressures. This is another patient, a HFpEF patient, giving you a similar kind of a feel of the effect of medical interventions. So this was, again, NYHA class 3 woman with heart failure with preserved ejection fraction. You can see the effect of escalating MRA dosing, increasing her diuretics. And then very interestingly, we get an alert because her PA pressures are rising. We look down and we see that her heart rates are uncontrolled. She's now developed atrial fibrillation. And with atrial fibrillation, her PA pressures have risen. So we give her a dose of metolazone and start her on some rate control, and her PA pressures come down. Then they start rising again, and we call her, and she's short of breath, a bit febrile. We send her to the emergency department, and she has a pneumonia. So again, a nice kind of case that, for several reasons, we can identify arrhythmia, we can identify other reasons for PA pressure rise as well. And also that AFib is associated with other medical conditions. Here's a nice example of what we do to our patients who have significant LV dysfunction, and we subject them to VT ablation. So I really like showing this to my electrophysiology colleagues, showing that not everyone is like this, but this was a gentleman with severely reduced LV dysfunction who was having a lot of issues with arrhythmia. You can see that his PA pressures and his heart failure hemodynamic status was quite stable, actually. But then he goes for a VT ablation. And if we didn't monitor him, he most certainly would have been admitted with a heart failure decompensation. But because he had the device, we were able to see this, monitor it, intervene, and bring his PA pressures back down to normal. So what have we learned from clinical experience, clinical trial data with this technology? So the totality of experience and clinical trial data really says people need to have good blood pressure because vasodilation and afterload reduction and heart failure with reduced ejection fraction are key. People need to respond to diuretics because that is also an important intervention. And so renal function or renal response. You can still have quite significant renal dysfunction, but as long as you're responding to diuretics, that's okay. Compliance is key. So if patients don't take their readings, don't give us the information, or don't do what we ask them to do medically, really not going to derive any benefit from this technology. Patients with heart failure can have symptoms that are not due to congestion, and really this device is not going to help if you've not demonstrated that they're prone to congestion. We also know that heart failure with preserved ejection fraction, we underestimate their filling pressures. And really the totality of this data indicates that really it's this patient population that seems to derive the most benefit. We've also known and have been able to manage people remotely entirely with this device. So, great thought for geographic limitations, people who do not have access to resources. There's a lot of other interesting possibilities with this as well. So optimizing our LVADs, post-heart transplant surveillance, response to pulmonary arterial hypertensive therapies, dialysis prescription. There's lots of thoughtful things that this may be able to help with. Some of the things that we learned and who will not benefit from this type of technology, really avoiding that end-stage heart failure patient who's at high likelihood of needing advanced therapies. Non-compliance is non-compliance. So again, you're not really going to derive benefit with this device. Kidney function. So if they've been proven to not respond to diuretics, that's challenging. You're not going to get benefit with this device. It's, the GUIDE-HF experience has taught us that it's not applicable to everybody. And so less sick patients likely won't derive the benefit, and it's likely not worth the cost. And so really the evidence would say that it's the class 3 heart failure patients with hospitalization that get the most benefit. So just for the sake of time, I think I'll just kind of move to remote monitoring programs in general. So, the success of remote monitoring programs is really highly dependent on many factors, right? So how the technology is implemented from a patient perspective will drive adherence. How easy is it to use? How easily can it be incorporated? We also have to understand the operational impacts and create resources needed to implement. Perhaps the most important of all is patient access to technology or its components, the mechanisms to enhance adherence. But we also have to be careful to continue to enhance therapeutic relationships and not completely eliminate human contact, as patients quite enjoy social interaction with their healthcare providers. We have to build in utility, link in monitoring with action that will increase patient engagement, as patient engagement is key and our patients need to be convinced and engaged. So clinical trials are important, but we really have to also be open to iterative implement and evaluate processes with available health technology to identify who and how should be encouraged. So where are we in British Columbia? So right now there's a provincial health technology assessment underway with the CardioMEMS technology, with aims at designing a provincial approach. And we're also part of a multi-million-dollar CIHR grant, of which one component of it will be looking at how can we apply heart failure phenotypes and match them to various remote monitoring strategies, because not every heart failure patient will benefit from CardioMEMS, this whole different strokes for different folks type thing. So which monitoring strategy would fit best with what type of heart failure patient, and how can we roll that out to benefit our patients? So in summary, remote monitoring programs have the potential for significant improvements in heart failure for the patient, but also the healthcare system. We need to focus on how best to integrate our available and emerging technology into care pathways that match monitoring strategies to the patient phenotype, improves health system efficiency, and enables broader access to specialist care. Our collective experience in providing care during COVID-19 has demonstrated the utility of virtual care, that yes, it actually can be done, and has highlighted the need for additional data from technologies to assist in remote care. PA pressure monitoring in itself and specifically has sufficient supporting evidence to expand its use across Canada, and integrating remote monitoring technology into clinical practice with the ability to evaluate its utility must become a priority. And with that, I will finish and hopefully have some time for some discussion and questions. So thanks very much.
Thank you, Brian. Maybe I'll just take the first question and then open it up to others for questions. In your ideal world, would this be for the right class of patients? You mentioned New York Heart Association class 3 and above, I guess. How often would people report, and who would they report to? Is it a daily report? How would you see it?
Yeah, so great question. So, I mean, it's important to realize the clinical trials were all comers. So it was a mixed bag of patients. So patients follow primarily by primary care, patients follow in a heart function clinic. The real world studies, so the UK, the European, and our experience in Canada, all took patients who were already enrolled in a heart function clinic. So there's evidence for benefit in all of these populations. So far, really, it's really in that sick heart failure population, right? So it has FDA and Health Canada approval for class 3 heart failure patients, and we know that heart failure hospitalizations from the data I showed has mortality risk to it. So being hospitalized for heart failure is a risk for death and is a bad prognostic sign. So the truest would say restricting it to class 3s who've had a previous heart failure hospitalization meets current approval for clinical indication. And we know that despite best efforts, about 15% of our heart failure patients are class 3. So it's quite a number of patients that would potentially benefit. But I would even go more above that and say it's really, in Canada especially, it's really going to have use, and our challenge is the geographic limitation patient. So the patient who lives in northern British Columbia, who has no access to specialists, this really is that niche population that this can really help, because our experience has been, certainly it's been mine, that you can manage these patients entirely remotely if they have a blood pressure cuff and access to a lab. So the program, everyone's program's done things a little different. We ran it that patients were instructed to take these readings every day. All they need is Wi-Fi or cellular. So there are some technologic requirements that they have to have access to. So it needs to transmit somehow, so Wi-Fi or cellular. They take readings every day. They're checked twice a week. And then it's a lot of active involvement. So there's a lot of healthcare resource up front. It's primarily nurse-led, and we develop algorithms. If the P pressures are still high, this is your first approach, this is your second approach. And then it's implement and evaluate. So you increase their afterload reduction, see what their pressures do, make another intervention if the pressures aren't coming down, reevaluate. So there's a lot of active monitoring that we know has to take place. So there's a resource implication with this technology. But once you're able to optimize them to either normal, or there's definitely patients you're not able to get to normal, but stable enough and kind of good enough for them. Once you get into that maintenance phase, as I said, the system is quite interesting in that you can set a threshold that the system will actually alert the healthcare provider once the pressure deviates from that upper or lower threshold. So the active monitoring can stop, so to speak, and you can just be notified by an electronic communication that, hey, you should go in and check this person's pressures because they've deviated from your predefined thresholds. So it is definitely more resource intensive up front. How most American centers have structured this, because it is way more widely prevalent in the US, and part of what we are trying to figure out is how best to roll this out in Canada, is how these monitoring programs look, right? So definitely hub and spoke, but definitely we know nurse-led, and physician supervised, similar to the heart function clinic model. But yeah, quite, if that answered your question.
No, that's very helpful. It's all about the utilization and resource. I mean, with the right population, and how would that look? So thank you very much. Yeah. Open to other questions.
Hello, Dr. Clark. Is just wondering how long do these things last for after you implant them, and like the battery life, and can you retrieve them easily there afterwards?
Yeah, great question. So they're not battery powered. So technically, they can last the patient lifetime. So patients who've been implanted, who want a heart transplant, for instance, can be useful to monitor things post transplant. But so technically, they last forever. So it's electromagnetic energy, so not battery powered. So it's the technology and the sensor itself that it's only activated and powered by the pillow the patient takes home. So it activates it, energizes it, and it snaps a PA pressure and heart rate and sends it. So theoretically, it can last as long as the patient lasts. There have been extremely few reports of sensor failures. So on the handful of like 10 or less, where the sensors have failed, and you can't retrieve them. So you can definitely repeat right heart caths. They endothelialize, kind of like a coronary stent. So if you remember what the picture looked like, it was kind of a sensor with Mickey Mouse ears. So the Mickey Mouse ears prong in the pulmonary artery, and the sensor sits in the middle of the pulmonary artery. So the endothelium of the pulmonary artery kind of forms a coating over the ears and holds it in place, and the sensor sits in the middle of the pulmonary artery. And it's far down enough that you can still put a right heart cath in or anything like that, but you never retrieve them. There's been 0 cases to date of over 20,000 devices of actually an adverse patient event related to the device itself. So adverse events mostly relate to the procedure, so bleeding or vascular injury or arrhythmia. We quote to patients that the worst thing that can happen to them is a procedural complication or the device moves. So if the device moves in the implant artery and moves elsewhere, you leave it where it sits. So the worst case scenario is that the device is not interrogatable, but it doesn't, cause PEs or anything like that. So we don't retrieve them if they move. They land where they land. But if you're doing the measurements right and you're procedurally savvy, that happens pretty rarely.
Any other questions?
Sure. Keith Wally. Fabulous talk, really interesting stuff. 2 questions. First one, do these PA pressures correlate pretty well with echo Doppler estimates? And the second question is, anyone using this for obesity, hypoventilation, to titrate CPAP, oxygen, diuretics, stuff like that?
So 2 great questions. So first we know, RVSP PA pressure by echo is not great. It's not always accurate both ways. So you can have elevated RVSPs and have a normal PA pressures on a right heart cath. So it doesn't really correlate well, and that's the limitation with RVSP non-invasively. It's not great. That always has to be confirmed with echo, and lots of interesting applications of this, right? Essentially, you're getting anything that has clinical utility in measuring PA pressures and LV filling pressures. So any scenario where that would be helpful to a clinician or a healthcare team, this device has potential use for. So there's been no clinical use for that particular indication, but if somehow there was a theory that it could help, like titrating CPAP, it's interesting.
Great, thank you.
Any other questions? So I'm sorry to take the chair's prerogative, but one other question. The reassurance that technology works, don't worry about it, has been a recurrent theme, except when it doesn't work. So give us your either personal experiences or the literature experiences about how the technology's confounded the situation.
Of this technology in particular, or generally?
Well, I'm not asking you to speak for the technology groups, but we all have had our own experiences.
Yeah. So, I mean, it's like everything and anything in medicine, right? You can never really hang your hat on one thing. what I can say with the experience with this specific technology is it seems to be, it works in that it does what it's supposed to do. So it effectively and reassuringly will send you pulmonary artery pressures. And it's got over 10 years now of use, that failure or inability to use is quite low. So for its design purpose, which is pulmonary artery pressure reporting, it's a fairly robust piece of technology. But how you apply that clinically to your patient may differ depending on any number of other factors. So, one thing that comes to mind is that example that I showed, that rising PA pressures don't mean heart failure, right? Short of breath, and someone with an EF of 20 is not always heart failure. So there are other things that can happen to people where you will see rises in PA pressure. So you have to prevent. This runs the risk of creating blinders, right? So that you have to resist, that wearing those racing blinders scenario, that rises in PA pressures don't mean heart failure decompensation. Just like we would say in the emergency, someone who's short of breath, it's not always their heart failure just because they've got cardiac disease.
Right. Thank you very much. Last chance. Any other comments or questions? I've always enjoyed grand rounds, and this one especially. The introduction to an understanding of new technology and treatment of a long known established disease, a chronic disease, and to make it less chronic and less of a problem. That's very interesting. Thank you very much for the presentation, Dr. Clark.
Yeah, thank you for the invitation.